everyone. It is our pleasure to welcome all of you to today's digital symposium, proudly hosted by Veiva Scientific in collaboration with J&J MedTech. This platform brings together leading experts to share their personal approaches, clinical insights, and real-world case experiences on the ever-important subject of complex PCI with Impella. We are privileged to have with us here our esteemed guest speaker, Dr. 𝐈𝐦𝐩𝐿 Bharadwaj, Director of Cardiac Catheterization Laboratories and Clinical Cardiovascular Research, and Associate Professor of Medicine at the University of Miami Miller School of Medicine. Thank you, sir, for sharing your time with us today. Before we begin, I would also like to express our sincere gratitude to our moderator and distinguished panel of expert panelists and speakers who have joined us from all across India. Your expertise and participation truly enriches this program. To guide us through this evening session, we have the honor of having Dr. Praveen Chandra sir with us as the moderator. Thank you, Dr. Praveen Chandra sir, for giving your valuable time to us. Without any further delay, I now hand over the platform to our respected moderator.
Thank you. Thank you, Gauravi. And I see a lot of my colleagues have already joined, so it is the right time to start this session, and we have great presentations today. So just to set the context as to why we are discussing this, and here I have some slides just to kickstart the whole thing. And maybe can you see these slides?
Yes, we can.
Yeah, okay, fine. And okay, fine. So basically, today we are going to discuss a lot about the chip PCI and MCS support, and of course, what are the workflows, how do we make it as safe as possible, and of course, the snapshot of outcomes, illustrative cases by my colleagues, Dr. Nishit, Anusha, Dr. Prem Ratan, and Dr. Dhananjay. All of them will be presenting quick cases. And then, of course, we will definitely discuss complications and how to prevent these complications, because in MCS, it is very important to try to minimize complications and get best outcomes. And finally, of course, we'll discuss what are the take-home messages from this discussion today. So as a starting point, of course, complex high-risk PCI, we all know these are the patient profiles which we are doing today in India. And high syntax score, surgical ineligibility, hemodynamically unstable patients. And of course, in these patients, we have now started doing routinely. And generally, the mean ejection fraction in these patients, as we see, is, as far as our center is concerned here, that about 1/3 of them were last remaining vessels. Low ejection fraction, 28%, mean ejection fraction is 28%. And then we have a team in place so that we have to work very closely with the entire team, including cardiac surgery people, the anesthesia, and of course the critical care. And then of course, many times we do some cases in hybrid cath lab, but most of the cases are done in the normal cath lab, perfusion support, and then of course ICU has to be ready to get these cases back and there, and then of course take care of them. So planning is one of the most important things here, which I think Aditya will dwell upon a little bit. And then certainly most of these cases which we select have, as I already told you, are complex anatomy, low ejection fraction, high surgical risk, etc. And then of course the other very important thing as a starting point is the vascular access, and the ultrasound guided vascular access pre-closure technique is something which is absolutely 100% mandatory in these cases. And sometimes alternate axillary access should be known if femoral arteries are unsuitable. And then of course anticoagulation protocols, real-time ACT tracking, and then of course bailout and escalation pathways, because many times patients can start kind of deteriorating and things like that. And of course, when we remove the device, etc., protamine reversal, hemostasis, all these things have to be. So we had the opportunity to do a clinical expert consensus document on the use of this device in India. And this is the small summary of that. As many of us, you may be knowing also that we score them based on the hemodynamic status, patient characteristics, coronary anatomy, and procedural characteristics. And then, of course, score them less than 3, 3 to 5, and more than 5. And this is just final slide of mine, just to show the total number of cases we have done, and most of them are high risk PCI. Cardiogenic shock is now increasing a little bit, and of course, single surviving vessel is one of the most important anatomical, coronary anatomical factors. Advanced stage, complex multivessel disease, unprotected left main, and heavily calcified vessels in many, many patients. So with this, I think, the experience is now gradually going up, and the procedural success has been quite good, about 94% procedural success, 6% complications, and that's all. So I think with this, I will stop here and we will go to the cases. And of course, before that, we will have a very detailed presentation by Aditya, and how do we select cases, how do we, kind of make a plan, and of course, how to monitor these patients on a continuous basis. So thank you very much. Aditya, please carry on.
Thank you, Dr. Chandra. That was an excellent introduction, to kickstart this webinar. So I'm going to be sort of giving a very a high-level overview of case selection. Then we'll delve into some data regarding the use of Impella and high-risk PCI. Then we'll talk about complete revascularization, and then we'll finish up with some best practices, which Dr. Chandra already touched upon. I also do have a case example of a patient that we enrolled in one of the clinical trials that I'm going to reference, called Restore-EF. So like was introduced during the introduction, I'm here in University of Miami. I recently moved here. I was in Loma Linda in California for 9 years, and I helped build the high-risk PCI and the cardiogenic shock program there. It was a very high volume center. We did everything there, cardiac transplants, VADs, etc. A very busy shock center. We did about 100 Impellas a year, combination of CP as well as Impella 5.5, which we used quite a bit in our practice. So with that introduction, these are my disclosures. So let's dive right into the big question that always comes up in the real world: who is the high-risk PCI patient? So just to start off with a little bit of an introduction, I think we're all very familiar with the ACC/AHA classification of the complexity of coronary artery disease. We often reference this classification in the cath lab when we're taking care of patients: type A, type B, type C lesions. Type A are the simple lesions, which are fairly discrete and non-angulated, non-calcified lesion. And type B are, of course, intermediate. And as we go to type C, these are the more complex lesions that we talk about: calcified lesions, bifurcation lesions, chronic total occlusions, etc. But I think what we have to remember is this just purely talks about the lesion characteristics. So the question then comes up: should we be considering more than just the coronary anatomy? What about the patient, the entire patient that is in front of us? And the answer to this question actually comes when you look at the kind of patients that we're treating in the cath lab. So this is data from the United States, but I think it is really applicable to really patients being treated worldwide. We are treating patients who are older, and we're treating patients who have more comorbidities than ever. So this is data looking at the last couple of decades. And as time has gone on, like I said, older patients with more comorbidities, more hypertension, more hyperlipidemia, more diabetes, more chronic kidney disease, more incidence of prior stroke. So I think it is definitely clear that we're treating sicker patients in the cath lab. The patients that we get a lot of times are ineligible for surgery. They have multivessel disease, and I think that says something about the comorbidities they have. So with all this background, it was first in 2016 that they proposed this concept of CHIP, or complex high-risk indicated procedure, which really is a Venn diagram where you have the intersection of complex coronary anatomy, which I think we're all very familiar with. But in addition to that, patient comorbidities or surgical ineligibility is a very important consideration. And probably the most important consideration is adverse hemodynamics. So I think no two patients are alike. And once you have adverse hemodynamics, which is characterized by depressed left ventricular ejection fraction, elevated left ventricular end diastolic pressure, presence of concurrent valvular heart disease, that really adds to the complexity of the patient on the whole. So we actually looked at data from Protect 3. Dr. Chandra just shared with us the data from his center in terms of the distribution of these different things of the patients who are treated at his center. And I can tell you that when you actually look at the data in the United States for over 1,200 patients who are all part of the Protect 3 registry, the data is very similar. So the three circles that I showed you, comprising of complex coronary artery disease, patient comorbidities, and adverse hemodynamics, it turns out that 82% of the patients actually were at the intersection of all these three, meaning that they at least had one risk factor of these three. And out of these, I think complex coronary artery disease, like we just talked about, when you have severely calcified lesions, when you have unprotected left main bifurcation lesions, these really are cases where there's a large area of myocardium that's in jeopardy, and those are the conditions where Impella is frequently being used. So this is just to reiterate again, this is retrospective data. These are patients who are already treated with Impella, and we did this analysis. We published it last year. And like I said, 82% of these patients actually fell in the intersection of these three circles of the Venn diagram. So with that background, I just want to get started with a case, and then we'll go back and look at more data. So this is a 78-year-old female that I treated a few years ago. Diabetes, hypertension, she was a current smoker, COPD. She had had history of colon cancer, which had been resected 4 years ago, prior stroke. And then she presented to one of our other outside hospitals with worsening shortness of breath, lower extremity edema. She was found to be in heart failure, AFib with RVR, and she also had elevated troponin. So she ruled in for an MI. They did a coronary angiogram, and then they transferred her to our hospital, which I'll show you in a little bit. But these were her physical exam findings. So irregular, she was tachycardic. Clearly, she was in heart failure, bilateral crackles. She also had a systolic murmur. And in terms of labs, elevated troponin, pro-BNP, elevated creatinine as well, 1.9, and an eGFR of 40. So I think it's very clear that this is a patient with multiple comorbidities and is in decompensated heart failure. This was her echo when she came in, AFib with RVR. So, irregular, it's always a little hard to estimate EF in these cases, but it was estimated at about 30 to 35%. And she also had about 3+ mitral regurgitation, like you can see on the screen. So this is her angiogram. So the right was actually non-obstructive and not much disease over there. But then when we shot the left system, it turns out that she had significant disease in her left main bifurcation. Like you can see here, it's a very calcified lesion involving the distal left main as well as the ostial circ. And a lot of hazy calcium even in the ostial LAD. So this really is a Medina 111 left main bifurcation lesion. So just to summarize, this is a patient, elderly patient, current smoker, multiple comorbidities, has severely depressed left ventricular ejection fraction, and has severe mitral regurgitation. In addition to that, she has calcified left main bifurcation disease. So this really is what characterizes a high-risk PCI patient. And of course, this patient was turned down for surgery. We got a surgical opinion. The surgeon felt that given her COPD, she was on home oxygen, CKD, prior stroke, all these risk factors being considered, she was deemed not to be a surgical candidate, and so she was referred for high-risk PCI. So this is case planning. I think Dr. Chandra made an excellent point about how planning these cases are extremely important. I actually sit down with my staff, with my fellows the day before, or sometimes even a few days before, to plan these cases. We do use right heart catheterization on a lot of these patients to understand the hemodynamics. So these were actually the right heart cath numbers, like you can see here. Despite diuresis, her wedge pressure was still 18, RA pressure was 12, cardiac index was 2.5. As far as the PCI strategy was concerned, I think we all agree that this is a case where you would consider upfront Impella support, also very calcified disease. So the plan was to do atherectomy of the left main into LAD as well as left main into circ. I think both vessels needed to be debulked. And I think we also would all agree that this is a case for a dedicated two-stent strategy. I don't think provisional will be a good choice here, given how much disease there is in that side branch, which is a large circumflex artery. So now let's break away from the case a little bit and look at what is the data supporting use of Impella in high-risk PCI in a case like this, for example. So we have data from PROTECT 2 trial, which is a randomized controlled trial, which randomized exactly the kind of patients that I just showed you into either Impella-assisted PCI or balloon pump-assisted PCI. I do want to point out that it was Impella 2.5 that was used in this trial. This trial was run in 2012, so it's more than a decade old. It's 13 years old at this point. The primary endpoint was 30-day and 90-day major adverse events. And these are the results from the trial. So if you actually look at the per protocol analysis, there was a 29% reduction in MACE when you actually followed these patients up to 90 days. 29% reduction by use of Impella as compared to balloon pump. A few things that I want to point out here is that it's very interesting to see that there was no difference in the in-hospital events, meaning that you can probably get the patient done safely on a balloon pump, as I think a lot of times we hear at conferences and other discussions that, oh, I can get this patient done on a balloon pump. I can get this patient safely off the table, which is true. But if you actually look at data from PROTECT here, it actually turns out that the benefits of Impella are seen at longer term, at 90 days and beyond. Unfortunately, this trial only followed patients up to 90 days. I think one of the criticisms or the commentary for the trial was that there had to be a longer follow-up. So that is what we're doing currently in PROTECT 4. But anyway, at 90 days, you do see that there is a significant benefit of using Impella as compared to balloon pump. So I just want to reiterate again, it's not so much in the cath lab, but what we do in the cath lab with complete revascularization, with modifying calcium, with using intravascular imaging. Impella allows us to do all these things and use all the best practices in the cath lab, and we see the effects and the benefits of that downstream at 90 days and beyond. And that is exactly what was shown in this trial. I also want to draw your attention to a subgroup analysis of this trial, which showed that the Impella benefit was more pronounced in patients who had extensive revascularization. And this was characterized, there are different ways that you can look at the degree of completeness of revascularization. There is the residual syntax score. Then there's also something called the ischemia zone score, which looks at how much of myocardium is subtended by the coronary artery disease that is left alone or revascularized. So anyway, the bottom line, the takeaway from this publication is that patients who had a more extensive revascularization, who had near complete revascularization, actually had greater benefit, had greater reduction in major adverse cardiovascular events as compared to patients who had limited revascularization. I think this is a very important point, and this is one of the things that actually distinguishes the benefit of an Impella as compared to a balloon pump or no support. It does allow us to do more complete revascularization. Another important takeaway from PROTECT 3 is the renal protection. And this is actually data that was published in 2019, which basically shows, I think we're all familiar with the Mehran risk score. Mehran risk score predicts the occurrence of acute kidney injury in patients undergoing coronary angiography and PCI. So the predicted and Mehran risk score has been very well validated, externally validated in multiple different cohorts and registries. And when you actually look at data from PROTECT 3, it turns out that the predicted risk for acute kidney injury based on the Mehran risk score was in the range of 22%, so 21.9%. But the actual occurrence of AKI was significantly lower than that. So that was very hypothesis generating that if you use an Impella, you can probably reduce the risk of acute kidney injury. So similar concepts arising from PROTECT 2 trial here. So what you actually see here on the right of your screen is the amount of contrast that was administered. So in the Impella arm, there was a higher amount of contrast that was used because these patients had more complete and more complex revascularization. But despite the higher amount of contrast that was used, there was lesser incidence of acute kidney injury in the Impella arm as compared to balloon pump. So again, this is very hypothesis generating. The trial was not powered to actually prove a renal benefit, but that is being done in PROTECT 4, for which we just completed enrollment, and we should have data as far as the renal benefits of Impella are concerned. So again, this is just the PROTECT 4 trial. We just wrapped up enrollment of this trial. Patients with ejection fraction of less than 30% with multivessel disease who were randomized to Impella CP, not 2.5, Impella CP versus balloon pump, a much larger trial as compared to PROTECT 2. And the most important thing is that we are going to have 3-year follow-up data as compared to 90-day follow-up data with PROTECT 2. So we at Loma Linda were one of the high enrolling centers, and I was fortunate to be one of the lead investigators on this trial. Like I said, we just finished enrollment, and right now we're gathering all the data for follow-up. Hopefully we should have the presentation either at ACC or TCT next year. So coming back to our case, so like I said, we elected to use Impella in this case. We decided to do rotational atherectomy. This was atherectomy of the left main into LAD. It was a 1.5 millimeter burr. And these are the results that we had on the right side of the screen. This is post-atherectomy. And once I made sure there was no dissection, I took the wire out of the LAD, put the rhoda floppy wire into the circ, and did rotational atherectomy of the circ, again with a 1.5 millimeter burr. And this is what we had. And like you can see here, this is on the right side of the screen. Basically, I just wanted to show that I'm using this guide extension catheter to actually deliver the left circumflex stent. And like you all know, guide extension catheters can be occlusive. And as I was doing this maneuver, you can see that the patient is completely dependent on the Impella. On the left side of your screen, you can see that the aortic waveform is actually flat. There's no pulsatility, but there's a mean arterial pressure of 60 with an Impella flow of 3.9 liters per minute that is being maintained by the Impella CP. So, and then of course, as far as the PCI was concerned, mini crush is what I used in this case. I used, I think, about 50-50 mini crush and DK crush. In this case, I decided to do mini crush, and these were the results. Before I show you the results, also very important to make sure that we do proximal optimization, final kissing balloon, and finish up with another proximal optimization. All of this was IVUS guided. And these are the final results, like you can see. And on the left of the screen is the IVUS pullback from the LAD back into the left main. And on the right of the screen, you can see that caudal view. And on the next shot, you can actually see the cranial view. We had good results there, good kidney flow down all the arteries. We used very little contrast, given that this patient had CKD. We were able to get it done really with, this was like a low contrast PCI, like we would say. Impella was actually successfully weaned off in the cath lab. I do have a low threshold for leaving the Impella in on these patients, but this patient actually tolerated the procedure very well. We did another right heart cath at the end of the case. There was no change in her cardiac power output or the wedge pressure. So we decided to take the Impella out. And she was actually discharged home 2 days later on an optimal medical therapy. And this patient was one of the patients that we enrolled in Restore EF trial. I'm going to show you what that trial is all about. But this is a patient, as part of the trial, she got an echocardiogram at 3 months. And, she was doing very well, asymptomatic, no hospitalization. Her EF actually improved to 45 to 50%. And with revascularization and medical therapy, her mitral regurgitation was now down to trace MR. So what is Restore EF? So Restore EF is a trial that we actually published 2 years ago. I was fortunate to be involved in this trial. So basically, the high volume, high operators were selected in the United States. We were about 15 centers, and we looked at all our consecutive patients getting Impella-assisted high-risk PCI. And what we actually showed that when best practices were followed and we did a complete revascularization in these patients, there was significant improvement in the ejection fraction. Like you can see on the right side of your screen, there's about a 10% improvement in the median EF. This is also the number that is seen with some of the drug trials like Entresto and SGLT2 inhibitors and all those things. So there's about a 10 to 15% improvement in the ejection fraction, and that was demonstrated with the use of Impella, best practices, and complete revascularization. In addition to that, we also showed that there was a significant improvement in heart failure symptoms and anginal symptoms, because I think we all realize that, of course, the numbers are important, improvement in the EF, survival are important, but if you actually talk to the patient, that they will tell you that what they really care about is how they feel. So quality of life is extremely important in these patients, improving the quality of life. So there was 76% reduction in heart failure symptoms and 97% reduction in CCS anginal class in these patients, and they felt significantly better after the PCI. So I'm going to wrap up in the next few minutes. I just want to sort of give you all an overview of when and how I use Impella in my clinical practice. So this is the algorithm that I follow, and I borrowed it from Dr. Samir Sharma from Mount Sinai. I trained there under him, and I borrowed this algorithm from him. It's a very simple algorithm, and that's what I like about it. I will tell you that it is sometimes a little too simple in the sense that we do consider more than just the ejection fraction. This algorithm is heavily based on the EF, but I think it gives you a good starting point. So really, I think the major takeaways are that, if you have an EF of greater than 35% and you're still doing complex PCI with hemodynamic compromise, usually characterized by elevated LVEDP or severe valvular heart disease, then you should still be considering Impella. This 20 to 35% is sort of a gray zone. And again, in these patients, if you're doing a simple PCI, you could consider Impella or no support. But again, in this category, if you are doing complex PCI characterized by an elevated syntax score, more extensive revascularization, left main bifurcation, calcified disease, etc., you should be using an Impella. And once you get to this really low ejection fraction, we have a lot of patients in our center with these low EFs who are transferred to us for consideration for heart transplant or VAD. Those patients are very, very sick. And in these patients, when the EF is less than 20% down to the 10 to 15% range, we do have a very low threshold for using Impella for unloading the heart. And that's what we do. Again, I just want to also share this workflow that we have in our hospital. I think the most important thing, like anything else in interventional cardiology, is case selection. These are cases that are discussed at a heart team meeting. 100% of these patients get CT surgery consultation at our center. And then we make a decision that, surgery is not the right thing for this patient, and then they get referred for PCI. Then case planning is extremely important. I think step-by-step planning in terms of what wire, what balloon, what is the PCI strategy. And then, of course, consider use of upfront mechanical circulatory support. This is something that we always do. We do not believe in bailout strategy. We do not believe in having a 5 French sheath just in case. I think if there is an indication for Impella, we go ahead and use it. And then, of course, best practices, following the best practices are very important. I have a slide on that. And finally, I think post-PCI care is also very important, making sure that these patients get discharged on their dual antiplatelet therapy, cardiac rehab are all very important concepts. So best practices, I think we can spend a whole hour talking about this, but I really just want to give you 2 or 3 takeaways from the best practices. The most important thing is planned upfront support for indicated patients and avoiding the strategy of bailout. I think the bailout things never work well. We actually have data that has been published by 𝐈𝐦𝐩𝐿 and others showing that bailout cases actually do significantly worse as compared to upfront use. So, these are obviously very sick patients with very low reserve, and when they crash, they really crash. So really bailout should not be an option at all. And the second most important thing, I think we all realize that large bore access is the Achilles heel of high-risk PCI. So it goes without saying that we should be very, very meticulous with large bore access, ultrasound, fluoroscopy guided access, use of micropuncture access, angiography for confirmation are very, very important. And I think we all also should get very comfortable with the per-close techniques and managing closure as well. So with this, I'm going to finish up. So just in conclusion, historically, high-risk PCI has been difficult to define, but I think the best way to define it is, when you have a combination of complex coronary disease, multiple comorbidities, and/or adverse hemodynamics. And that is what we showed in the PROTECT 3 study. That is also exactly what Dr. Chandra showed, that majority of these patients that do get Impella-assisted PCI in fact, do have all these three characteristics that we just mentioned. And I also want to reiterate the point that, we have data showing that Impella protects the kidneys. This is being studied in PROTECT 4 trial, but we also have data showing that it improves the ejection fraction and decreases angina and heart failure symptoms. And finally, I think, this is a great technology, a great tool, but it is on us to use best practices so as to decrease the complications. So use of upfront Impella and meticulous large bore access is very, very important. Thank you. So I can take questions now, or we can do questions at the end. I'll leave it up to Dr. Chandra.
Dr. Chandra, you're
You're
muted.
on mute, Dr. Chandra.
I have already unmuted. So can you hear me?
Yes.
Okay,
Yes.
great. So I think it was a great overview of what exactly where we are in terms of Impella usage. And of course, in India, the major issue is the cost factor of Impella. But still, we have cases where we can do it. Now, the most important question is that given the cost and given the use of other devices like intra-aortic balloon pump. So let me ask you a question, Aditya, whether IBP is still available in US, or the only MCS device available is Impella?
Yeah, no, definitely IABP is still available. And
Oh,
we don't use it for high risk PCI though. To tell you very frankly, the only indication that we use it in is in patients who have chronic heart failure who go into cardiogenic shock. Again, not acute MI cardiogenic shock. Acute MI cardiogenic shock is a very different population. The ejection fraction, their cardiac output goes from 6 liters per minute to 1 liter per minute. That's very different. The patients who have chronic heart failure, their body has acclimatized, their body has gotten used to a low ejection fraction, and then they decompensate. They just need that extra half a liter output, which balloon pump provides. Those are the indications where we use balloon pump. But for high risk PCI, we do not use balloon pump.
okay.
Unless,
Okay. Thank you.
there is a mechanical aortic valve or there is an LV thrombus.
Okay. So we will take one question or one comment from Dr. Srinivas Kumar, who has already joined as a panelist here. So Dr. Srinivas, would you have any comment or a question? And then we'll move to Dr. Nishit Chandra. So we're changing the schedule a little bit because Nishit has some important engagement. So Nishit, keep yourself ready. We'll have your presentation and then we'll go to the next one. So Dr. Srinivas.
Thank you, Dr. Pavin Chandra, and thank you, Aditya, for the excellent talk highlighting the how to use Impella. It's very useful for us where we started using. I think all of us who joined here maybe have done about 10 or 15 Impellas, unlike Dr. Pavin Chandra, who himself has done more than 100 cases. But I think in your discussion, it looked like most of it is happening. Revascularization leading to heart failure, pumping function benefits and all is more of revascularization benefits, I feel, rather than Impella benefit. What do you feel?
Yeah, I think that's a great comment. Definitely, I think revascularization along with GDMT. I mean, GDMT in heart failure is, we all know that it works very well. It decreases mortality. So I think revascularization with GDMT is really what is leading to better outcomes. But the revascularization is happening with Impella support. Like I said, it allows us to do complete revascularization. It allows us to do calcium modification, intravascular imaging. So we have the time to actually do all these things and protect the heart, protect the kidneys. So I think Impella is allowing us to do that revascularization, which is then helping improve survival, improve heart failure symptoms.
I keep jokingly telling that it is like going in a good high-end Benz car while doing the compared to vis-a-vis a small Maruti while doing the procedure. It gives us so much comfort for the operator and no worries of fluctuations of pressure and no bradycardias arrest and all that. Is a great comfort to the operator. That is certain. But it is a costly comfort in the type of high-end bench car types. But anyway, it's actually very good. As you keep using it, you would like to use it more, but for the cost things, I think. With this, I'll ask Praveen Chandra to hand over to some. You said somebody else to come.
Yeah.
Nishit.
Dr. Srinivas, thank you very much for your comment. And I think Nishit is ready with his presentation. So Nishit, would you like to start now?
Yeah, so is my screen visible?
Not yet.
I've already shared.
Technical team, can you help him?
Sir,
I've already shared it.
please share again, sir. Because
बीच में दिखा था सर फिर अभी
Okay, so I'm sharing it again. Okay, is it visible
Now
now?
it is coming.
Yes,
Yeah.
yes.
Yeah.
Okay.
Yeah.
So first of all, thank Dr. Praveen for accommodating me out of turn. So, and I think we all are presenting our TCT presentations like Aditya, and Aditya has set the stage for my presentation by giving us all the requirements for Impella and the protocols and the evidence. So this is a case which I presented about a week ago in TCT, and this also highlights the use and the benefit how Impella helps in navigating this very complex anatomy and a very complex patient. So this basically gentleman referred to me from Indore. He's right now 67 years of age, diabetic, very poor LV and having severe angina to the extent that he was not even able to go to the toilet unassisted without any with severe angina. And he has a very long, illustrious history starting from 1994, and when he was just 36 years old. So let me illustrate it further, just for the clarity. So in 1994, he started having angina, and he had a right coronary artery, which was treated by plain simple balloon angioplasty. Now, this plain balloon angioplasty served him well for next 25 years, when in 2019 he has triple vessel disease, and this time he landed up with 𝐈𝐸MA Y and an SVG2 PDA, so triple vessel graft. But so he was a highly diabetic patient, uncontrolled diabetes. So this bypass graft also did not work, and it got blocked, and he came back in November 24 to in Indore Center, and there, to the dismay of the cardiologist, they found that all the grafts, including the celebrated 𝐈𝐸MA graft, got blocked. And the SVG was also blocked, and he was left with severe angina and severe triple vessel disease, and RCS progressed to CTO, and there is a LAD and a circumflex disease. So the team at Indore, they decided to treat the LAD in November 24, and they basically put a stent in this is a 275/38 synergy stent in proximal LAD with the help of IVL. This they did in December. So a patient landed up with to me in August with angina, and this time when I checked, there was a severe blockage of the stent which was put just 6 months ago in Indore, and with all the grafts blocked. So what are the challenges in this case? The challenges in this case is we have a sole surviving LAD with a stenosed stent, the RCS CTO, all his grafts are closed. So, and probably this stent was an undersized stent with an underexpanded stent with a peristent calcium, and the ejection fraction was very poor. So the management plan is, should we redo CABG? But the chances, all his grafts were taken, the 𝐸𝐸MA, SVGs, so surgery was not an option. So the only whatever the treatment left with us was a supported PCI. as Dr. Chandra has already mentioned about the consensus statement, so we applied this consensus statement to our patients. We saw that yes, his ejection fraction was less than 35.1. He was turned down for surgery, not an eligible candidate for surgery, 1 mark, and only remaining conduit vessel 2 marks. So, and left main requiring left main multivessel atherectomy, yes, 1 mark. So his total score was 5. So he was in this category of strongly consider that Impella support. So with this, we proceeded with Impella CP. We implanted that, and the angiography showed that this is the LED, which is sole surviving vessel, and you can see that there is a discrete in-stent restenosis in the proximal LED. The stent was put just 6 months ago, 27538 stent synergy. So what is the cause of this ISR? So for that, we have to do an imaging. So, but for imaging catheter to track in this, we had to first pre-dilate it. We pre-dilated with 22512, and then it made some room for the IVUS catheter to be passed. And to our surprise, not surprised, we were expecting this, that there was a very severely stenosed stent, constrained stent by a peristent calcium. You can see the MSA was only 3 millimeters square for a 275 millimeter stent, which is more than 80-90% stenosed. So this is the problem which we were dealing with, a severely constrained stent with a peristent calcium. Now, what are the options treatment? This is an undersized, underexpanded stent with a peristent calcium. What are the treatment options? The treatment options could be intravascular lithotripsy or 𝐈𝐸𝐻 laser. The lithotripsy was already tried at the center outside in Indore. So we decided for 𝐈𝐸𝐻 laser, and we proceeded with 𝐈𝐸𝐻 laser. Just for the uninitiated, the principal mechanism of action briefly is 𝐈𝐸𝐻 laser. There's a 3 mechanism of action. The photochemical first, which breaks the molecules, then photothermal, which basically fulgurates the calcium, and then photomechanical, the acoustic, the sonication of that. So these are basically the 3 mechanisms by which the laser works. And so, and the settings which we do for laser, there are only 2 settings. One is fluence, one is Hertz. The fluence is basically millijoules per millimeter cube. It's basically determines how much power and how large the balloon, the bubble would be. So larger the fluence, larger would be the balloon, larger would be the bubble. And not only that, the laser also, power of laser also is dependent upon which media which we are using, whether this is saline, blood, or contrast. So though contrast use is not included in the IFU, it is off-label. But in our case, we used contrast. So we started with 40 fluence and 40 with a saline flush, and then escalated to 80 fluence with the saline flush. And then we did an IVUS. So IVUS showed that we did not gain much purchase, and it was still not broken. The calcium was not broken. So we upgraded our strategy to 80 fluence with a 50% contrast, which is off-label, of course. And so after that, when we did the IVUS, we found some evidences of fractures, calcium fractures. And then after this identification of these fractures, we dilated with the NC balloon to 2512. And then we used a cutting balloon 27510. And we used OPN balloon to further dilate this stent. So OPN also we used 2.5 initially, and then escalated because to 3, because after 2.5 the MSA was 6.9, which we were not very happy about. So we escalated the OPN to 3 and jacked up the atmosphere pressure to 40 atmospheres. And this time when we did the IVUS after this, we found we could get a reasonably handsome MSA of 8.2. The starting point was 3. So from 3, we could safely expand to 8.2, guided with the help of intravascular ultrasound. So we did not want to put another layer of stent. So we ended up our case with coating the stent with a drug-eluting balloon. This was a sequin paclitaxel coated sequin please balloon 340, and this was our final result. This was the pre. You can see 3 millimeters square constrained stent, and post was 8.2 millimeters square. So this was pre angio. You can see this discrete stenosis, and this is post angio. So it's been, we did this in August. This has been 3 months now. The patient is doing well. Telephonically, he's in contact with me, and he's now able to even go for walks in the park. So, ladies and gentlemen, to summarize, in-stent restenosis with an under-expanded stent is increasingly being encountered in our interventional practice. And in these type of patients with sole surviving vessel, Impella is not an option, but it is mandatory, because Impella has made this case and rather given us confidence to sail through this case safely, utilizing all these atherectomy, all these measures, OPN balloons, cutting balloons, and ALCA. So thank you very much. If there's any question, I'll be happy to answer. Thank you.
Thank you, Nishit. I think it was a wonderful case, I must say, and truly, representing how Impella supported this case so well. And definitely, one small comment about, your handling this case was perfect. But one, short point is that, probably ELCA is not a great device for severe degree of calcification. And I think predominantly when you escalated your OPN to, with 3 and going up to 40 was the key to success. And of course, the support which you already had with Impella. But nevertheless, great case. And I would like to take a quick comment from one of the panelists. And I think Dr. Suraj is here. Dr. Suraj?
Yes, sir. That's an excellent demonstration of a complex case. Sick patient, single surviving artery, multiple interventions in the past, and the use of imaging to show what is the mechanism of the failure of the stent. And like you rightly pointed out, the laser actually made the lesion and the calcium little softer so that the OPNNC can open it further. And this is an excellent case for using a hemodynamic support. So, and once you gain the lumen, it is not necessary to put in another layer of stent. Rather than putting in the layer, I would have also opted for using a drug-eluting balloon like what you have done. And I totally concur with all the steps which you have done in this procedure.
Great. So thank you, Nishit. And we'll move on to the next presentation by Dr. Anusha. Dr. Anusha Rao, is she ready? I don't.
She is in emergency. I think you can take the next case, I think.
So, okay, so we can take the next one. So who is Dr. Prem Ratan? Are you next in order? Dr. Prem Ratan?
Yeah. Yes, sir. Yeah, I'm ready, sir.
Okay, please go ahead.
Yeah.
Please go ahead. Yeah.
So allow me to share my slides. Yes. So everyone is seeing my slides?
Yes.
Yes, yes, yes.
Yes, 1 second. So, yeah. I'm audible to everyone?
Yes, sir.
Yes.
Yes,
Hello?
yes, yes, yes.
Yeah. So my case is then a 69-year diabetic hypertensive male patient who had the stenting to LED in 2010. And this patient came to me 6 months back. and he was the known case of CKD. His baseline serum creatinine was 2.1. So when he came to me, he was with the non-ST11 MI. Ejection fraction was 25%, and LVID slightly dilated 5.6 centimeter. And this was the angiography of this patient. And you can clearly see that the LED stent has the ISR, and the distal LED is diffusely diseased, and the diagonal and all microvascular circulation is slightly compromised. So, and this was the right side, and you can see that distal RCA has 90%, 80-90% stenosis, and even the middle RCA has this significant plaquing, and PLV has the moderate disease. So I sent this patient after seeing the ISR, ejection fraction 25%. So I did the cardiac MRI for the LED viability. So the LED was viable in the cardiac MRI. So I sent this patient to the bypass, to surgery, because the already has the ISR. So, but somehow the surgeon denied and asked the patient to be on medicine for some time. But within the 1 month, patient has the recurrent heart failure hospitalization. Again, he came to me for the non-ST11 MI. So that time it was clear that now we have to take the patient for the PCI because the surgeon has denied for the surgery. So it was decided to do with the Impella CP protected PCI. So the routine we use the right or left femoral, which is so with the Impella into the LV, and you can see the various steps which are not everyone knows about the how to Impella. We can put the Impella from the right or left femoral artery and wire in the LV with O18 wire in LV. Over this wire we can put this Impella CP, and we can see the cardiac output in the monitor. And this was the angio after the 1 month, and you can see that the disease has progressed so fast that even the distal LED and it's so progressive, and this was the RCA, and you can see that now the RCA has also 100%. So there was the disease progression was very high. So we decided, because this was the 100% and there was no significant ST elevation in the inferior lead, so we decided to do first the LED. So with run through wire in LED, with the starting from the 2 into 15 mm balloon followed by 2.5 and 18 mm balloon, we pre-dilated this previous stent with the because you can see that there is this large septal, single septal with the osteostenosis. So we also protect this large septal and with the filter wire, and we did the cutting balloon, that is 3 into 12 cutting scoring balloon. We did all the way into the LED, and after that kissing dilation with the septal 2 into 2 mm balloon with the, so that after taking this we put around 3 into 14 mm synergy stent from the mid LED to the ostial LED, and after the multiple dilation, and you can see the results of the LED with the synergy stent. And this for that, and for the right we put 3 into this is the right one, and with the wire this you can see with the wire that RC become open, and with the multiple balloon dilation. One second. Yes, this is the 338 stent we put in the distal to mid RCA, and that was the final result after the putting the stent. And now we have the 6-month follow-up. The patient is doing very well, and this is the case where we can see this. We can see that without Impella, this case would not be possible, because the ejection fraction 25%, patient was in severe LVF, and because we have to take call. So with the Impella CP 3.5, we could complete this revascularization in this patient. And now the EF is improving from 25% to 30% in this case. So my case is very straightforward because this is the Impella protected PCI, and the essentially we can't do without this protection. That's all from my side. So
Thank you, Dr. Prem Ratan. I think it was again a very good case, and thanks for sharing your case. It really adds to the experience of all of us, and I'm glad that you're taking up so complex cases. So with this, I will take one small quick comment from Vishal. Is already joined. So Vishal, can you please give your comment or any suggestions on what Dr. Prem Ratan just presented?
I think Prem has done very elegant job doing complete revascularization in this patient. My only thoughts here are that when we take over these sick patients and we are having protection with the Impella device, we cannot just simply forget the hemodynamics. We should be monitoring these patients throughout the procedure, and we should also have we should be attentive towards what's happening to the pulmonary artery pressures, what's happening to the cardiac power output. Though of course Impella CP gives us all these figures on its own, but we have to still feed the cardiac output in the very beginning. And if the cardiac output is not correctly fed, then all the information that we get later on is all presumptive, and we don't know exactly what's happening. So to take the decision whether the patient is able to tolerate the procedure well, whether the patient can continue on, should be continued on Impella, or we can take it, remove the Impella on table itself. We need to have some monitoring, as Aditya and Dr. Chandra already highlighted, that the best practices are very essential to optimize results when we take up these complex patients.
Right. So thank you, Vishal. I think this is a very important point you raised. When to explant. So the point here is that hemodynamic monitoring during the case is supreme, and that is what will tell us whether we can explant it now or after 6 hours or after 12 hours or 24 hours. And then another very big important point is, because many people who have not done follow-up of these patients in the ICU on Impella, it is really very important to understand how we monitor these patients, because they will have issues of hemolysis, they will have issues of movement of the catheter, and of course the local site issues, that bleeding, etc., are the very important things. And that is why we will discuss maybe at the end of these presentations, but certainly it was a very important point that hemodynamic, and of course PA catheter is something which is very simple, and most of the times we do put a PA catheter. I hope Aditya, you agree with this, that using a PA catheter is a very simple and safe thing to do when you are treating such kind of sick patients. And even if I'm not using Impella, still I use PA catheter in patients who have low ejection fraction, last remaining vessels, and to see how they are tolerating these procedures.
Yes, absolutely, Dr. Chandra. I think PA catheter gives us a lot of information. Like Dr. Rastogi also mentioned, the baseline is to understand what the baseline is and how it has changed during the course of the procedure. Because when we're doing revascularization, atherectomy, and all these patients, a lot of times acutely they have myocardial stunning and their LVEDP goes up. We're also using contrast. So acutely, their hemodynamics may actually worsen before it gets better. So in that acute phase, it's really important to keep the LV support, so as to, prevent any hemodynamic compromise when they go to the unit.
One more thing, Dr. Chandra, if you permit me, which is very important.
Sure.
It's very important for the sake of all the people who have logged in. What I wanted to highlight was also pre-procedure planning and preparation of patient also goes a long way. If you suppose you can stabilize a patient, because the elective PCIs I'm saying, you can stabilize the patient little, probably diuresis them better, and optimize the things before you take up. And probably, unless it is some contraindication of anesthesia, probably it should be equivalent to a surgical procedure where you probably take care of the anesthetist, will take care of the ventilation part of it, and then probably you concentrate on the procedure. So these things like pre-procedure planning of the preparation of the patient also is very important apart from using Impella on the table. Though it gives comfort, but how you are starting also is important, I think, for taking of the patients. Thank you.
Absolutely. Srinivas, I think you have brought up the points very well. And, we were doing these cases and then we realized that there has to be a support team. So we have developed a support team of about 7 nurses who do round the clock in these very high risk patients who are undergoing ACS or acute MI interventions or cardiogenic shock interventions. And they remain at the bedside of these patients completely all throughout, so that they will know exactly how to communicate, how to manage, and how to monitor these patients rather than the routine staff which is in the ICU. So that is something which is really helping us carry forward these patients during the night and during the follow-up period in the ICU. So thank you very much,
Dr.
Srinivas.
One question, Praveen Chandra, for you, in your experience, how many have
Yeah.
removed Impellas on table? How many have continued ICU? By and
Yeah,
large,
yeah. So by and largely we explant it on the table, but many times we have to really continue it, and we remove it in the next 6 hours or the next 24 hours. But let me tell you, keeping the Impella in the ICU is another ball game. Doing it in the cath lab is absolutely different, and monitoring and following these patients in the ICU is absolutely different thing altogether, which people have to learn as to how to, monitor them, the hemodynamics, the urine output, the hematuria, the hematocrit levels. Everything has to be done very carefully, and of course the positioning of the catheter based on the echo, we have to really take care of that. So those are the things which are really important, and that is why adequate understanding of all these things are very important. And so we do about like maybe 2 or 3 out of 10 we will explant outside the cath lab.
Can I
Thank
just
you.
make a
Good
very
one.
quick
Yeah.
point, Dr. Chandra? So for those patients that go to the unit with Impella, I would also highly recommend bringing them back to the lab for removal. It is a little bit of an extra time to bring these patients back, but we implemented that 2 years ago at Loma Linda, and we saw a significant reduction in bleeding and vascular complications when they come back to the cath lab for removal. It's a more controlled setting. You have nurses and techs who are trained to hold pressure. We're monitoring their hemodynamics continuously. If they go vasovagal, you're able to quickly act upon it. So I think bringing them back to the cath lab to remove the Impella is also something that I would really recommend to consider.
You can also check how after removal, how you do it for TAVR. You can take a shot and see whether there's no obstruction or anything with the post.
Absolutely.
Okay.
I think that is absolutely essential. So should we move on to the next presentation? Yeah. If the next presenter is ready, please go ahead. So who is the next one? Dr. Anusha is not here. Dr. Dhananjay, are you doing the next presentation?
Okay, sir, I will present.
Okay.
Am I audible, sir?
Gauravi, who is the next presenter?
Am I
Yes.
audible?
Sir, we can go ahead with Dr. Dhananjay because I think Dr. Anusha ma'am is not available at this point.
Okay, no problem. So let Dr. Dhananjay start.
Sir, am I audible?
Yes.
Yes.
Okay, thank you, sir. So first of all, very good evening to Praveen sir and Aditya sir. I met in this TCT to Aditya sir in one of the workshop session or in a meeting, close meeting with the Impella guys. So this was about a patient 70, a female presented within 4 hours of chest pain and shortness of breath. She was hypertensive, dyslipidemic, non-diabetic. So her pulse rate in emergency was 180 to 120 per minute, systolic blood pressure 70 mmHg, respiratory at 24 to 28 per minute, and SpO2 around 88 to 90% on full oxygen. ECG was suggestive of extensive anterior MI and equal suggestive of ejection fraction of 30% with almost a stent LED territory with mild MR. So we immediately took her to cath lab. Did her NGO, the LED was thrombotically occluded from the proximal part. The LCX had tight lesion at the junction of OM, and the RCA had another tight lesion in the mid part with the length of lesion is almost diffuse. So we did her primary PCI to LED under the backup of IABP, as I am practicing in Ranchi and I don't have the excess of Impella all the time. So I did this primary with IABP and the flow was good. The patient hemodynamics, although she was on high inotropes along with IABP, and we transferred to ICU with high dose IABP and high dose inotropes as well as IABP. Her chest pain subsided, breathlessness persisted, for that needed an IV support for a few days. And the SPP, systolic blood pressure, remained around 100 mmHg on IABP plus noradopamine as well as vasopressin on moderate dose. But the ST elevation settled, echo remained the same, the eGFR was preserved somehow, and SGOT, SGPT mildly raised. Even after 3 to 4 days, any attempt of weaning from the IABP, the BP was further falling down and the need of inotropes escalation was requiring. So there was some sort of cycle, any trial of IABP weaning, like 2:1 or sorry 1:2 or 1:3, the requirement of inotrope was rising. So we decided to do complete revascularization, and we asked the CTPS guys, but they were not ready to take the patient in such a high risk situation. Even nor the relatives were ready for the those high risk mortality, perioperative mortality. So we opted for complete revascularization with support of Impella CP. We have started with RCA. Though RCA was calcified, but it yielded with cutting balloon, Wolverine, and high pressure NC balloon. So this was the calcium ring, but it yielded very well, and this was the outcome of RCA. Thereafter, I attempted LCX. Again, the LCX was critically stenosed as well as calcified. Simultaneously, the angle was not supporting any hardware to go, but I took a balloon, anchor ballooning to the LED, previously a standard segment, and thereafter it was easy to cross all the cutting balloon as well as days, and this was the result of LCX. So after LCX, I did the IVUS imaging to the LED. The LED, the recently stented segment, the proximal start was at around the 50% plaque. So, and the ostium of the LED was around 70% plaqued, as well as the ostium of left main was also 20 to 30% plaqued, and the left main was short around 6 to 8 mm. So after preparation, I decided to give a crossover stenting from left main ostium to LED with some 2 to 4 mm of overlap. And after post-operation of the previously stented segment and thereafter gave 424 with safety wire in sinus, and thereafter this was the result. It has been now more than, but the patients had a requirement of ionodrops, so I continued the Impella for next 14 to 16 hours. The patient, as Chandra sir were discussing, that the if your team is not well versed with the Impella in CCU, you might get some difficulty in managing those things. So definitely during the early morning, some sort of obsession with the bed sheet change or some patient, the movement was much more. Patient had chest pain. It was parietal type of chest pain. It was not cardiac. The ECG was normal, stable. BP was stable, but she had extreme grade of pain that was associated with the movement. And I was trying to reposition the Impella, but she had sometimes it was relieved, but many a times it was again appearing. So I decided to remove the Impella, even though patient was on moderate anodrops in terms of NORAD as well as DOBU. So I removed the Impella. I am accepting it. I removed it on bedside, and thankfully everything was okay. I had already put it probe light, so I closed the vessel there, and the patient remained stable. It is now around 1.5 years, and she is doing perfectly well. She is coming in every month in follow up, and so this was the her in last follow up. This is basically, this was the slide prepared for EuroPCR. This case was accepted in EuroPCR. So around 8 months back, later her ejection fraction had improved to 40%, and GLS had improved to around 9 to 10 minus 10%. So she is doing extremely well. Thank you.
Thank you, Dr. Dhananjay. I think again, a very good demonstration of carrying forward this, the use of MCS support in such high-risk patients. And this was like a cardiogenic shock patient where you had, taken this patient up for complete revascularization using Impella. So, but the interesting aspect was, as I was telling, that in the ICU, you faced difficulties and then you explanted it. Let me tell you one very interesting thing that, once the positioning is slightly affected, we should do it only under echo guidance. And I know, very many years back, there was a case where the Impella got, pulled up into the aorta, and one of the physicians who was there on duty at that time, he started pushing it in, and it all got crumpled up, and it was with great difficulty that we could take out the Impella catheter outside. So that is something which is important. And also, once we had a Impella catheter which got stuck at the calcification, huge calcification in the aorta. The patient was having a huge, badly calcified aorta, and it got stuck over there. And with some techniques, we had to take it out. So those things happen. So one has to be aware of that. So with this, any comments from my other colleagues who are here? And otherwise, we can go to the last presentation of this session by Dr. Anusha, if she has joined. Otherwise, we can take some final, takeaway. Yeah.
I think one improvement which
one
No,
comment
Anusha ma'am has joined.
regarding that
Okay.
patient.
Sir, Srinivas sir, are you asking something?
Yeah, no, one improvement which has to come there, I feel you can't thread the wire to make it straight. That's where it gets stuck and all that. So there are some further modifications, I think, that needs to come up in the Impella. Once you remove that
Yeah.
straightening thing, then you can't put it. It looks so simple, but it looks so stupid. You can't, you have to
Yeah.
just pull it out. So that's where I think you land in trouble, so it's getting stuck somewhere. And because we are always habituated in putting a wire, making things straight and pulling it out.
Yeah.
Right. Okay.
Right.
Thank you.
So Dr. Anusha has joined. So Anusha, you can start your presentation now.
Good evening, sir. Sorry, was running a bit late today. This was a case that we had done earlier September this year. He's a 76-year-old man, hypertensive, with history of progressive breathlessness since 2 months, orthopnea since 2 weeks, all worsened within matter of few days also, and with a history of hepatic artery pseudoaneurysm, post-hepatic artery recoiling in 2019. Echo was showing a regional wall motion abnormality with LAD territory almost akinetic, thin, dilated LV with EF of about 22%, create about 1.9 baseline, and the peak it had reached was 2.2. BNP was more than 25,000. Admission drop, HS drop was more than 600. 2 sets done, about the same range, 600, and the other one was 300, downward trend. And this was his angiogram, low contrast. And based on the angiogram, possibly LAD looked definitely non-viable. Echo also proving the same. And a large aneurysmal circ, left main as well as circ with a tight stenosis in the circ. And the RCA, which looked a little less challenging compared to circ to begin with. But RCA also had somewhat like a long segment lesions, 2 lesions, one around the mid distal and the other one very distal RCA. And without much thoughts, the next what we thought was how to go about this patient. LAD non-viable, giant aneurysm, lot of challenges, creatinine being 1.9, EGFR around 35, CHIP score high, syntax score high, reduced LV. Clearly, more than LV, patient was also presented with heart failure. So multiple reasons why to just upfront think about a protected PCI method. And as planned, we went ahead with Impella guided PCI, and this was the DSA. So history of hepatic artery aneurysm also, and aneurysm within the coronaries, aneurysms in the groins, as such not extensively evaluated for the aneurysm part of it though. But this was a micropuncture guided groin access which we had taken. Wire crossed into LV using AL1 catheter. Not much issue, but the issue started here. So if you can see, the artery, abdominal aorta is grossly tortuous, and tracking a 14 French device through over a 014 wire became quite a bit of challenge. So the main issue at this point, we also thought, should we do a buddy wire technique, keep a stiffer wire by the side and then track the Impella device. But the problem was the device, the distal end of it was not coming out of the sheath itself. So it was stuck in the introducer sheath and we couldn't really do anything, just pull the sheath slightly back and we could somehow manage to negotiate. At this point, we were frankly thinking we would not be successful, but luckily things turned around and we could successfully go on with an Impella. Puncture pressure has been around 90, 60 kind of thing. And this was what, after the Impella was started, we had a constant pressure throughout the procedure. So assuming RCA would be less challenging, we went ahead with RCA plasty first. So RCA was wired with an FC, little bit failure, then took a pilot, then crossed with a pilot with bit of challenge there. So every time in the distal cap would not enter and we would end up going into a dissection kind of plane. So there was a bit of a challenge in wiring RCA, which we took quite a bit of time. And after finally successfully wiring RCA, again, there's a challenge that comes because of the anatomy. We went with the guide extension almost through and through the procedure, and pre-dilated and stented the mid-distal segment of the RCA with good results. And all this was done post-dilated, and all this was done under NIRS IVA's guidance. And this was the 𝐈𝐦𝐻𝐿 post RCA PCI. Good apposition. Not some amount of malapposition was still noted, but as such, overall didn't show much of a problem in that junction. But however, still that very distal lesion did show started looking bad, and we had an Impella in place, so we thought, why not? Let's just go ahead and fix that as well. That was the thought process. So these are basic, the other still images of the same RCA. We post-dilated further and got optimal results and went ahead for the distal lesion. At this point, the guide extension is much deeper inside to negotiate the stent, and we could successfully go ahead and stent the distal RCA as well. It was a short stent, giving a good final results with RCA. We began with RCA thinking it would be a little less challenging and SIRC would be far more problematic, but ended up seeing that RCA was more problematic. Here, this is the left. Then we moved on to left main and circplasty. So wired the circ, surprisingly not much of challenge. So you can see there are further OMs also which are tightly stenosed, but the focus here was to fix mainly the left main stenosis and the ostial circ stenosis to achieve a far better result. And this was the pre-𝐈𝐻 of left main circ aneurysm. So at this point, problem is we have a distal vessel reference of about 8 mm, proximal vessel reference about 10 mm. MLA is about 2.8 millimeter in diameter, 7.3 mm area. MLA is 7.3. So pre-dilated, this is a 6 into 20 mm balloon. Sorry. Yeah. So post pre-dilatation, decent amount of result. So again, at this point, we just paused, thought, what next should we do? Should we just leave it at POBA results is what we were thinking. And this was the post balloon 𝐈𝐻. Some amount of reasonable expansion around the MLA site was noted. Good area, reasonable areas were achieved. Should we leave it at this? Should we go ahead is the question of thought here. So covered stents as such did not look like an option. Coil embolism, not an option. We are already in an Impella PCI, so surgically not fit also. Not just about considering surgery upfront. He was essentially not fit, LAD being non-viable, and accessing circ territory would be a little bit challenging. So at this point, at our best interest, we thought just go ahead with the DES, used a 5 into 20 mm synergy, just covering the stenotic segments, essentially trying not to land in anywhere of the aneurysmal segment. So that was the point of treatment. As such, there's no hardcore guidelines for these, but then at least make sure, at least it's more important to make sure that there's no under-expanded or under-expansion at the MLA site is also a very reasonable decision. We went with a 6 into 20 mm NC, post-dilated with at 20 atmosphere. The MLA achieved, around the MLA, the area achieved was about 26. There was definitely some amount of, in fact, significant amount of malapposition that was noted. There were like few proximal struts, if you can see in this part, there were few proximal struts that was actually hanging within the aneurysmal segment. So as such, we could not do much. The other areas, if you can see, was looking quite reasonably well expanded, but it was only at that proximal segment where there was a significant malapposition. And we thought we'll use a simultaneous kissing balloon here. So one more wire was introduced into circ, went with a 3.5, 15 and a 4.5 into 12 mm. We thought, at least in our minds, it would give a good result, but somehow, as such, the MLA or at the MLA site, minimal luminal area set, it did not show much of a difference. It was still about 26 to 29 millimeters square area, which was achieved. At least satisfied that we tried doing further upgradation of the dilatation. This was the pre and post final results that we had achieved with 𝐸𝐶. And after this patient has been coming for follow-up, so he's come for follow-up twice now since it was done early in September. He's been doing well. We did use quite a lot of dye in this patient, but luckily it didn't really affect the kidney parameters. His parameters remained continuously stable. He was monitored over next 2 to 3 days in the hospital, and Impella was immediately removed post-procedure, but he maintained well, and second follow-up is also done. He's doing well right now. Thank you.
Nusha, I think this was a very challenging case. And I say really did very well with this case and fantastic outcome. And to start with, I mean, even thinking of doing such a case was really, really very challenging. And even crossing wires in stenosis before which there is a big aneurysm is very, very difficult, I must say. But you could handle that. But just a word I will add here, that if you have aneurysmal segments before and after, it is not necessary to really go after that. We can just dilate these segments and some part of the stent may be hanging. I don't think it really matters that much. But nevertheless, I must say that fantastic case. And thank you very much for sharing it with us today evening. We respect your busy program today. But any comments from my colleague here on the panel? Please go ahead just now.
I just had a quick question.
I see.
Yeah. Was that a long sheet that you used for Impella?
Yes, sir. It was.
It was a long. Okay.
Yeah,
despite that, you encountered
yes, despite that. So it was just the Impella device that would not negotiate through the distal end of the sheath. It was just not coming out. It got stuck. So we just tried to retrieve it a little bit and then tried to renegotiate, which helped. So before that, we actually tried to take a stiffer wire, kind of a buddy wire kind of technique, so that aorta would straighten up a little more, but it would not come out of the sheath because the device was jammed within the sheath. And that was the problem. After at least about 5-10 minutes, after all of us skipping a beat, it finally could cross. So yeah,
that was phenomenal. Crossing that, tortuous aorta.
On an 014 wires.
Yeah. There is also a 35 centimeter Cook sheath, 14 French sheath that I have used a couple of times in these kind of situations. So it is longer than the long sheath that comes with the Impella. So just something else to consider, because once you have opened the device and you've told the patient you're going to use it, if you can't put it in, that's not a good situation.
Sir. Absolutely. That was the thought process we were going through at that point in time.
Thank you very much. And I think we are almost at the end of our session today at 9 p.m. So any final comments from Aditya? And then we can close.
Yeah, thank you, Dr. Chandra. No, thanks for inviting me. I think this was a phenomenal session. 4 different cases highlighting, different aspects. I think all very practical, in-stent restenosis with underexpanded stent, cardiogenic shock, complete revascularization. And then, of course, we have all these other cases like aneurysms. So I think all the cases were amazing. Great use of Impella. All the best practices were followed. So I think this was a phenomenal session, and I look forward to continued engagement with all of you.
Thanks, Aditya, for joining us and sharing your such a huge experience of using Impella. And certainly, we will have some more sessions in the future. And thank you very much, all of you, for joining today evening.
Thank you.
Thank you. Bye-bye. Good night.
Sir.
Thanks a lot to our guest speaker, and thanks a lot, Dr. Praveen Chandra, sir. I extend my heartfelt thanks to all our expert panelists as well as speakers. Until we meet again the next time, thanks a lot. Have a wonderful evening ahead.
Thank you.